Hello, sir.
How are you?
I was okay. Today I have a very bad cold. I don't know what happened. I was all right.
Doctor, good evening.
Good evening. Good evening.
Good evening, madam. Fine.
Happy New Year.
Hi, Sharat.
Madam.
Hi, Gopi. How are you? Hi, Priya.
Fine. Fine.
Happy New
Hi,
Year.
Happy New Year.
Hi, Saranya.
Gopi, Happy New Year.
Unmute. Unmute.
Hello, sir. Happy New Year.
Hi, how are you? Happy New
Good,
Year.
good.
Gopi, Happy New Year.
Happy New Year, Sharat.
Good, good. How's everyone at home?
All good. All good. So far, so good. How is Coimbatore? I think Coimbatore is settling down.
Coimbatore is fine, sir. All back to normal. No corona, nothing.
Mhm.
Officially, corona is out.
Waiting for the vaccine.
Waiting for the vaccine, yeah. Chennai is okay, sir? Everything
Chennai
back
is
to
fine.
normal.
Chennai is fine. About 200 and odd cases per day.
Okay.
But we had a 3 days back, we had a 2-month-old baby with COVID positive.
Oh, okay.
My goodness. And
Does it have any
It was
significance?
ventilated. Today it is waned off and then doing fairly all right, but COVID positive. No other symptoms.
could be the first in the south then, I think. La?
Mm.
Could be the first in the south. I think.
Audience number.
பெரிய விஐபி அது
Oh.
டிகே பட்டம்மாள்ல
Mama. Yeah.
அவங்க கிராண்ட் டாட்டர்
Oh.
நித்யஸ்ரீ மகாதேவன்ஸ் எல்டர் சிஸ்டர்ஸ் டாட்டர்.
Oh. நித்யஸ்ரீ ரெண்டுமே எங்க கிட்ட தான் டெலிவரி. But okay, so her older sister's daughter. No, daughter.
Daughter.
Daughter. Oh.
What, Sharat? What news? How did you celebrate the new year? Frozen bottles, huh? Because his next door is frozen bottle.
I know. Gopi. Had the second baby.
Oh, good.
Wow.
One more girl is added to the family.
Nice.
Oh, that's when was it?
Yesterday,
Yesterday, is it? Where was the delivery?
here in Indigo.
Indigo.
Yeah.
Oh, very good. Convey congratulations to Srilata.
Yeah, I'll tell her. Yeah, sure, Gopi. Your blessings she needs, no? Yeah. Both the mother and
Srilata was looking after our ultrasound for some time. It seems
good. All your good wishes, no? Definitely, Gopi.
nice.
Yeah, how's mommy doing?
Okay, sir. So far, so good. Just like how sir says, that's my answer you get. So far, we're all okay.
Good.
Up and down, but it's okay.
Yeah. How are the children?
Yeah, children. So 12th, 11th,
Abba.
9th, Amma. Now 12th is for the exams are postponed to May, no?
Okay.
Month is gone for us.
Hello. Start பண்ணலாமா?
Yes, sir.
Yeah.
1 minute.
Yeah.
Good evening, doctors. It is great pleasure for us from Shield to welcome each one of you for today's webinar, which is going to discuss about the important aspects in male infertility management. Of course, we have got the galaxy of eminent speakers today. The whole program is going to be coordinated by Dr. P.M. Gopinath. And I have great pleasure in formally introducing Dr. Gopinath, who needs no introduction. Dr. P.M. Gopinath is the Director and Senior Consultant in SRM Institute for Medical Sciences. Doctor is the President-elect for Fertility Preservation Society of India and a member of International Fertility Preservation Society. And Doctor is the Chairman of Board of Studies, Tamil Nadu Dr. MGR Medical University. And he is the Founder Secretary of IFS Tamil Nadu Chapter. Of course, there are many major achievements for Dr. P.M. Gopinath. You know him as a very passionate teacher, very nice human being, who is always willing to help everybody, whether it is academics or anything personal. Our sincere thanks to Dr. Gopinath and the entire faculty, because the entire faculty very spontaneously they accepted when we put the proposal. Dr. Priya Selvaraj, Dr. Sharath, and Dr. Saranya, our sincere thanks from Shield Healthcare. And I request Dr. P.M. Gopinath to take over the scientific session further. Thank you very much, Doctor.
Balaji, you would like to introduce the other speakers also?
No, sir, you will be taking one session after the other. We'll introduce the speaker, sir.
Okay, okay.
The resumes are with me.
Yeah.
We can show it, sir. Share the screen.
Fine. Fine.
Just my name and the designation will do, sir.
No problem, no problem. We all know that you are very popular than the President of India. See, the male infertility as such has been gaining very much of importance because the days have gone where when you have no issues, nothing to offer except for donor insemination or an adoption. Today, there are a lot of things have worked out. So this has kindled more interest in the ART person and also from the patient point of view. There is always a good light is seen at the end of the tunnel with this male infertility in the current era. So we have gone through various ups and downs in male infertility, right from semen analysis up to an ART. And there has been stormy periods where somebody has just mentioned that this has not been the standard. Somebody has just come forward to say that this has been against the vaccination. So there are a lot of things to settle down in this era. So to begin with, we will have the first speaker, Dr. Priya Selvaraj. And it is a very simple and basic thing. What normally we just say is the game of numbers. So that is the count, motility, morphology, and all. Now, she's going to just bring about the evolution of the semen parameters, and more importantly, its clinical significance, what we have to do at what stage, and where we have to step up and then do the rest. So over to you, Priya.
Thank you very much, sir. Thank you. I think that's good. Is it seen, sir? Is that okay? Is it seen?
No, yet to be seen.
Oh, okay.
Stop sharing and share again.
Okay, sir. 1 second. Stop share.
Yeah, now share again. Yes, ma'am. Yes, ma'am. Ma'am.
Is it seen?
Yes, ma'am.
It's seen, right?
Yes, ma'am. Yes, ma'am.
Okay, so I'll just proceed because I'm not hearing it from anybody else or sir also for that matter. Fine.
Yes, sir is
Okay,
on a
so,
call.
okay, I'll proceed, okay?
Yes, ma'am. Yes, ma'am.
So good evening to all of you, and thank you very much, first of all, to Shield Healthcare, as well as dear Dr. Go at the very beginning of the year. So wishing you all a very happy new year and a blessed new year ahead. So like sir said, I'm going to be giving a very basic run through, which everyone is familiar with, but hopefully I'll be able to add some more significance to the evolution of semen, or rather the examination of semen in the IVF lab. So what is the value of basic semen analysis? So I was thinking, let me start with this, where we all accept that the semen analysis represents a screening tool because that's the only way we can evaluate male factor. And one thing we know for sure, we'll be able to diagnose azoospermia or severe oligospermia. But does it mean that it has very limited significance? Well, we can possibly give you a relative fertility potential. We can definitely give you severity of the problem, and that maybe we can also prove that this could be the only factor or one of the factors contributing to the infertile status of the couple. But I will be reflecting in my conclusion slide why it cannot be the absolute end all of everything. So just a quick reiteration to the basics. So on one side, I've put an anatomical slide. On the other half, I've put a physiological control of spermatogenesis and spermiogenesis. Why we need to basically know this is to know the different parts of the male reproductive system, because whatever is happening here is going to reflect on these semen parameters during analysis. So anything to do with anatomical disruption or dysfunction, any blockages, any inflammatory issues will reflect. As at the same time, if there is a genetic component where we have chromosomal issues, where we have any situation where the hormones are less, like in hypogonadotrophic hypogonadism, that is also going to be reflected in your semen parameters. So let us quickly look at the composition of semen. We all know it's a fluid conglomerate, and it contains two fractions. One is the cellular fraction and the other is the acellular fraction. So when we look at the cellular fraction, we are basically looking at the sperms, which form only about 2 to 5% of the total ejaculate, while the rest of it is contributed by the seminal plasma. And when you look at the other cells outside of the sperms, we are looking at leukocytes or WBCs, we're looking at immature germ cells, and we're looking at epithelial cells. Now with a trained eye, these may be simply seen on a wet mount, but if you want to confirm specific conditions, you might have to do additional testing. I'm not going to go into those in great detail. I have only 15 minutes, so I'm going to cover the basics. So the acellular fraction, you have the seminal plasma, and you have all the secretions contributed in the seminal vesicles and prostate glands. They have extracellular vesicles called epididymosomes and prostosomes, which are nothing but fluid-containing vesicles, which contribute to the seminal plasma. So the minimal volume by WHO criteria is 2 ml. It's always an alkaline pH, 7.2 or more, possibly 7.2 to 8.2, and you have a minimal total count of 39 to over 200. So in that previous slide, you can see that the first slide has immature germ cells, but that's after staining. So it has a whole large condensed nucleus. So that's how you differentiate. Second one has the WBCs with the red arrows pointing there. And the last one is an epithelial cell. So origins of the ejaculate, I'm going in the order of ejaculation itself. So we'll start with the bulbourethral or Cooper's glands and urethral glands, which contribute to 3 to 5%. Then you have the testicular and epididymal secretions, which are 7 to 10%. Then you have the prostatic, which is usually acidic and contains zinc and spermine, etc., which contributes to 15 to 20%. Then you have the seminal vesicles, which is alkaline secretion, and they contain the prostaglandins and fructose, which form the majority, sometimes 70 to 80, 90% of it. These are all approximates. So why should we know all of this? Because if we are going to be a clinician, or if you're going to be an embryologist, we should be able to report it in such a manner so that every part of this series of ejaculate or the fluid as such is going to reflect in your analysis. So we have, why do you have the bulbourethral and Cooper's glands? Because during foreplay, this is the first emission that takes place, followed by the first part of the ejaculate, which normally contain the maximum number of sperms, which is from the epididymis and ampullary part, and also contributed part by the prostatic. And then you have the vast majority from the seminal vesicles. So in case sometimes you're looking for a split ejaculate, where you want to collect in two different containers, the first part of the ejaculate and the second part, either for some therapeutic reasons, then you should understand which part of it contains the maximum concentration of sperms. So if you look at indications for split, then you have like a hyperviscous sample. Then if you know that the patient has ASAB, because in a wet mount, if you're suddenly seeing agglutination, then so later when you want to do IUI or whatever, you might want to give them a split ejaculate, 2 containers, so that you'll reduce the secretions from the prostate and seminal vesicles, which contain these antibodies. And also sometimes we might give them a container with media so that you can dilute the anti-sperm antibody titers in those. Now, just a small note, because the embryologist is going to face this in the lab, if they see, if suddenly the clinician writes, get a split ejaculate, or, if the embryologist feels they need one, or it's a case of retrograde ejaculation, there is nothing in the ejaculate. So then you should understand that this is because the ejaculate has occurred in the bladder due to the following reasons, like surgical interventions, diabetes, neurological issues, any drug-induced causes. And for this, what the embryologist will do is they will centrifuge, they'll collect the post-ejaculate urine sample and centrifuge that at 1000 RPM for 10 minutes. In case there's no pellet, you do it again for 5 minutes, discard the supernatant, prepare the pellet as per your lab protocol, and then see if it is utilizable for either IUI or IVF. I haven't seen a case in quite a few years now, maybe even more than 8 years, I haven't seen a case. Semen analysis reporting. So this is the WHO. What I've highlighted is all of these we see in the lab, of course, and we are all familiar with the values. We don't do the fructose on a regular basis, and occult blood also, only if it is a suspicion, then you do further testing. Otherwise, infections are normally treated beforehand, and everything else is reflected when I talk about the steps of semen analysis. This is a basic overview of terminologies. Again, this is familiar to all of us. What kind of terminologies we'll be giving during reporting. So just to have one important one, if you have a disturbance of all the 3 variables, that is your count, motility, and morphology, you term it oligoactinoteratospermia. And then you have where there is no ejaculate, it's aspermia. And if the whole thing is normal, it's euspermia. And the semen analysis, which is generated, is called the spermiogram. And is it really necessary about to get an abstinence before semen analysis? Does it make any sense? For quite a number of years, I don't know why, even without a scientific basis, I kind of did not believe in abstinence, because I just tell them I want to first see a random sample, then we will think about how it was, because they'll anyways give you a history about previous centers, what happened and things. So first you give a sample, then you analyze it, then you see whether you want to redo anything. So I came across this wonderful paper by Dr. Pandian sir and Dr. Radha Pandian madam, and they had analyzed 2037 Tamil men, where they found that with different periods of abstinence, there was really no statistical significant differences among a normozoospermic sample and an oligozoospermic sample. So that is on concentration, motility, and morphology. There seem to be no vast differences. But however, the group with the less abstinence, no less than 24 hours, had the highest mean percentage of progressive motile sperm and normal sperm morphology. So this paper, I've put it up there so you can always read it. It's very simple and it's very neatly done. And here are the instructions. I purposely left out abstinence there. It is each one's own protocol. So first of all, the patient has to write their name and computer number, ID, whatever it is. Then they have to be asked to evacuate the bladder prior to ejaculate. Just to minimize contamination, they have to remove the lid at the time of collection and replace the lid immediately after. No washing or trying to do anything with the containers. They have to masturbate directly into the container, no use of contraception or any kind of lubricants, and we don't advise coitus interruptus. So coming to steps. So as soon as you receive the sample, now going forward from here, I'm just going to highlight why we are doing these and what is the significance. So quickly to run through, we all know that the physical appearance of semen is what we see as soon as the container comes in. As it is lying in your laminar flow, you'll be checking all of this odor, and then you'll see if there is any, very obvious contamination or color change, like a very yellowish sample, maybe pyospermia, you might see blood tinged discoloration. If it is very watery, you might think there is urine in it, but it is usually grayish to yellow opalescent color. Then you quickly take your number. You've already written the name of the patient on the graduated pipette, and then you quickly check for consistency. So here you will do two things. You will also know the consistency by letting it out dropwise manner and checking the viscosity by seeing if the thread formed is less than 2 centimeters or more than 2 centimeters. And you'll also be able to see the volume at the same time. So many things you finish quickly, and then you let it rest for the liquefaction. Why do we look for liquefaction? It's a proteolytic process. So what happens in nature is that the whole ejaculate becomes a coagulum in the female genital tract, and then it becomes watery. And why? Why is there a specified time? Why does this happen? Upon ejaculation, it forms a coagulum because it's entrapping all the sperms and having a protective network, a gelatinous network. And this is a beautiful paper that I've put here. Please read it. And so the gelatinous network is formed by secretions from the seminal vesicles by seminogelins, which entrap. It's protecting the sperms so that later, because the vaginal pH is acidic, these sperms are in an alkaline medium, they are protected. Then the prostatic secretion through the kallikrein 3 hydrolyzes these, and then it becomes very watery so that they gain straight away entry through the cervix into the site of fertilization, which is the ampullary part of the fallopian tube. So that's very interesting, I thought. And if you are still stuck with a sample which hasn't liquefied at 30, at around half an hour at room temperature, you leave it for another half an hour in the incubator. And if it is still viscous, then you aspirate and expel it through a 19 gauge hypodermic needle, which does not have any, the syringe should not have any rubber components. Now, what are the effects of pH and why are we testing it? So we have to test if this person has an acidic or alkaline pH. And if you notice, it's given here, both the way it is being done, where you drop one drop of semen on the pH paper, and you already have this available. So you can see the color gradation, and the color change is denoted there. It's next to 7, there is a nice greenish discoloration. So that denotes this is a normal sample. So why are we checking pH is because seminal plasma contains bicarbonate and carbon dioxide ions and inorganic ions and so many other bases and proteins, and they have a very good buffering capacity compared to other body fluids, and they enable progressive motility and capacitation and acrosome reaction. All this is dependent, even the intracellular, that is in your sperm head prior to fertilization or egg entry, there are calcium activation or influxes that take place, which is all dependent on this pH. So that is why it's important for us to know. So this study by Zhu et al. they had concluded that alkaline conditions will stimulate sperm motility and capacitation. And if there is any disturbance in the sodium, potassium, ATPase activity, which is caused by an acidic environment, it lowers the motility and pregnancy rates. And also there might be a plasma membrane damage of the sperm, which reduces capacitation. Now, motility. So while you're doing all of this, you will also be trying to prepare on the side a wet mount. Basically a wet mount will give you most of the information. So you will swirl the sample, then take a 5 microliter, put it on a glass slide, you'll put a cover slip on it, remove all the excess fluid by dabbing it with a tissue paper. Then you'll examine it and count about roughly 100 spermatozoa. You go methodically by moving the glass slide up and down, right and left. And here you'll quickly see, you can quickly assess with the trained eye basic count, motility, whether you see a lot of forward progression, whether you're happy with the sample, are there a lot of debris, and also motility, which is the most important, rapid progression and totally immotile. This is enough for now. And also one more thing is agglutination. So when you're doing this wet mount, these are the points that you will see. And what is the significance? All of us know about motility issues and of course counts. But agglutination, how many of us actually go ahead and test for anti-sperm antibodies? Is it a routine in your practice, or do you do it only for specific people where you suspect it because you see agglutination in the sperm sample? How many of us are able to identify it? All these are queries that can be discussed later. But it is supposed to signify to a certain extent an immunological disturbance of fertility. And the most important test to actually diagnose is the immunobead test, and not just by looking at this. We do a serum test, and we kind of have it like a screening method for all patients, especially those who have had failed IUIs. And we don't do the immunobead test, but I've put it here for theoretical reasons. And we do not see much agglutination on our wet mounts actually that often. And because now you have sperm washing and everything, you don't have to worry about it too much. Sperm count and concentration, we use the Meckler's chamber. And the Meckler's chamber, so here is a grid, okay? This is a grid. Usually people read on a Newbart chamber. And you wipe the Meckler's chamber clean, and then you put a 10 to 20 microliter drop, and then you put the slip, the lid of it. It'll disperse very evenly, and then you observe it under a phase contrast microscope. So roughly speaking, the corner squares that has been marked in the center picture that you see, the number of sperms that you see in all of this is actually read at 20x, which roughly corresponds to the concentration of the sperm, which is number of sperms per ml. And then from there, you can calculate the total sperm count. And the other way to do it is you just randomly count 10 squares and then converted that into millions per ml. And if you don't see very many sperms for a trained eye, you will then start looking at all the squares and trying to come to a rough figure of how much the sperm count should be reported as. And morphology. So strict morphology criteria we are all aware of, and Kruger's criteria. So this is a slide which depicts in a very nice way about what you should expect with the head width and mid-piece and tail, and how much of the acrosome should occupy the head area. So things that we can commonly see even if we look under the microscope, we should be familiar with. Head, very common head abnormalities, pinhead, globosospermia, tapering, long tapering head. Then the acrosome, how much of it is covered. Then the mid-piece, how abnormal, the tail defects. And so we use everything from cryolab. We use a pre-stained slide. Otherwise, you have to do the Leishman's technique. So you place a 10 microliter drop on the slide and place the cover slip. Allow it to dry for 20 minutes and observe it under oil suspension. And this is, all these are our lab pictures done by my lab girls, so big thanks to them. So she's now she's now using the cell counter and hitting the button for whatever abnormality she's noting for this particular patient. So this is from Dr. Franklin's slide for us. He had come here and taken a class. So you can see the different kinds of abnormalities. This is actually an exam paper where the embryologists are asked to identify the different abnormalities. So if you notice, majority of these you might certify it as normal. And but if you look at it closely, there are only 1, 2, 3, 4 that are marked normal in green. And clearly you can see how the acrosome occupies 40 to 70%, how the midpiece is very neat and the tail is also beautiful and the shape of the head is perfect. But many of them look very similar, so you have to be very, very skilled or maybe very vigilant to note the midpiece and head abnormalities. So if you look at the condition of teratospermia, how does this come about? Is there a treatment? So in the next slide, I'll put up the paper, which is still in press by Oringer, and it's a beautiful paper. It is 2020 Infertility Sterility. So these are the various causes for your morphological disturbances. So not only do you have the lifestyle, you also, of course, with oxidative stress, you also have endocrine issues, hypogonadism, then you have, of course, our thyroid dysfunctions, other endocrine Cushing, so many other things. Then you have genetic mutations. So if you find multiple abnormalities in the person, it is very unlikely to be a genetic reason. It is mostly a lifestyle, or it could be somewhere originating from the germ cell and Sertoli cell abnormality itself. But any monomorphic abnormality is usually genetic, and it is by autosomal recessive inheritance. So aside of all of this, what do we do when we get a teratospermia sample? See, it gives you a prognosis. Of course, it gives you a prognosis about how the fertilization, everything is going to be affected going on from there. But in IVF, that is. But if you're going to use ICSI, you have a better platform to select for your patient what is close to normal or what your eye see as normal. And they realize that there is good fertilization because trained people are doing ICSI, but it does not really affect anything with the blastocyst and formation. So by using ICSI, you can possibly override most of the abnormalities. There are papers that show even by using globospermia sperms, they have attained pregnancies. So maybe in event of teratospermia, you could combine selection by ICSI and then possibly do a PGTA to give them a complete wholesome treatment, because aneuploidies do have a relationship with this, but it's not the strongest correlation. And next is the vitality, eosin nigrosin stain, everybody knows. So the principle is that the intact cells who have the plasma membrane intact, they will exclude the eosin dye, so they will appear white. And the nigrosin is usually a counter stain so that you're able to see and visualize these dead sperms and live sperms against the background. So what we do is, again, here also we use cryolab. So it's a pre-stained slide. So you mix 50 microliter of semen sample with the eosin nigrosin suspension, mix well, make a smear on a glass slide, allow the slide to dry for 20 minutes, and then observe it under oil. And then you can see the white, and the pink ones which are stained are the dead sperms. Now, if suppose you are seeing the sample and you report it as, everything is dead, there's necrospermia, and what do we do next? What are you going to tell the patient? Of course, we have to look at all the reasons that could have caused this particular condition. And then you also have the advantage of using the host test. And if you do the host test on these people, you will be able to tell them whether they have any chances if they come for an ICSI cycle, that is for an ART, complete ART program. So it's based on the principle that when you expose live spermatozoa to moderate hypoosmotic stress, they are able to sustain that, and they're able to not allow their heads to swell up and rupture, and they will maintain the integrity of their plasma membrane. Instead, the tails will curl. So earlier, I just roughly looked this up from the book, and we used to try to prepare this, but now it's luxury because we have labs, cryolabs supplying you with the media, pre-prepared media. So you receive a sample from the patient, everything is done as usual. If you want to do the host test, try to do it soon after the liquefaction. And then you prepare it just like how we mentioned before, and you observe. So this is also a lab picture. And if you see closely, there is a curling of the tail at the end to show that it's a viable sperm, which you can use. And okay, so these are the causes of necrospermia. These are 2 papers that I had read. What do you really do? What is the treatment? Can you really treat? So all these conditions, right, from again a thyroid dysfunction to lifestyle like substance abuse, even advanced age, then prolonged periods of anejaculation, anti-sperm antibodies, having a condition, polycystic kidney disease, any sort of infections, even a varicocele, so many contributions. So what they say is first you try to identify a specific cause. If it's not there, then we as usual will go ahead and do a complete andrological workup, including hormones and everything, maybe even get a karyotype done, because polymorphisms could be associated with this, we do not know. But if there is a genetic or a molecular reason, you can't treat it. So again, you try to go and do an ART cycle and do a host test and select sperms and try your best. Otherwise, the only thing that is left is to go into the testis and procure sperms. And then we also added this to our semen analysis report, where we check for reactive oxygen species. And for this, you use the agarose N gel tube, which is first incubated in boiling water until gel melts. Then you place the melted gel tube at 37 for 5 in your incubator. Then you add 200 microliters of semen to the tube and mix it gently. And you can see the color change after almost an hour. So this, you correlate it with a chart that is already provided, and you can see this has a high level. The dark purple is high level of ROS. So you treat the patient accordingly. You just have more information to talk to the patient and tell them, when we see all of these things in the lab, this is what we inferred, and this is what we're going to do to enable you to get pregnant. So with all this that we have, I'm not touching the advanced sperm function test because it's going to be covered by the next speaker. I also did not go into great details about, checking for fructose, fructose positive, fructose negative. Fructose positive means obviously the SVs are working well. And if it is negative, you obviously have a case of congenital bilateral absence of VAS, which is also associated with absence of seminal vesicles or dysfunction. So we don't go into great depth in our lab. So I'm just giving that as a very theoretical thing. And we do the others, but but I'm not covering it here. But just to conclude, you have 100% infertile sperm and 100% fertile sperm. Somewhere along the way, you've been given the knowledge and research to check for the basics, which are the count, motility, and morphology, which is very important and vital for sperm function. And there is no doubt in questioning why we are doing all of this, because it is related to either genetics or our lifestyle. And at the molecular level, there are so many pathways. The research is enormous. The papers are enormous. So within 15 or 20-minute talk, I cannot cover all of that. But again, going forward, DNA integrity or DNA fragmentation testing, when do you really apply it? How do you go about it in the lab? And you have the undetermined molecular factors, which are always going to sit there. And you'll always be wondering, okay, how do we diagnose all of this? And how do we give them a complete picture of their infertile state? So I don't think we need to sweat too much. If we just know the basics, and if we do the basics, and like Sir said, the opportunities are umpteen for men to, somehow get their wives pregnant by so many laboratory techniques. But this is just for us to know that you have so many undetermined molecular factors still lurking in the background, which will create a challenge for us. And with this, I end my talk. That's just our very simple semen analysis report. We just have only this happening in our lab. And I end my talk. I hope it was useful. Thank you very much. And I'm sorry if I overshot any time. Sorry about that.
Thank you, Priya. Thank you for taking us through the semen analysis. We have covered almost everything possible in this very short time. And it was quite nice to see some of the slides being shown to say how exactly we are doing it. And we'll move on to the next speaker. The next speaker is Dr. Sri Saranya. Can I have the CV, please? And she's a clinical embryologist from the Danube University of Krems. Senior embryologist, has been practicing for 2 decades, and now she is in PhD super specialty hospital. And Saranya, I have been associated with her for quite some time. She's been very sincere, very hardworking, and then she'll be up to the point. So we all know that we do semen analysis, but then there is something called the special firm's function test. Whether are they of any relevance in clinical practice? Whether are we doing it today? And what is the importance of this? She's going to highlight to us. Over to you, Saranya.
And thank you, Shield Healthcare, for the opportunity. Thank you, Dr. Priya, for covering all the basics. It was very good, actually.
Thank you so much. That's great coming from you. Thanks.
Thank you. So after Dr. Priya has covered the basics, I think we'll just go over to the sperm functional tests and its clinical relevance. So Dr. Priya has already gone through this. So what do we see when we do a normal semen analysis, which is now being done in every fertility center? So we do a macroscopic examination to see the volume, pH, consistency, and color, odor. And then we do a microscopic examination of the sperm to see the concentration, to see the motility, where we grade it into progressive, non-progressive, and immotile, and morphology or the vitality testing for the sperm, where we look into the head, neck, and tail defects. We also look into the acrosome. So these no doubt give a very good insight into the male infertility, contribution of the male into the infertility. But is this enough? That needs to be seen, because what is our goal? Our goal is to isolate the most competent sperm. And why do we need the most competent sperm? It is because it is the one with the most fertilizing potential. And this fertilizing potential of the sperm can be compromised due to a number of issues, multifactorial issues, in fact. So the biochemical issues play a role in this, physiological issues play a role, morphological issues play a role. And within a single ejaculate, the sperm morphology varies to a wide extent. One sperm can be a picture perfect normal sperm, whereas the other sperm in the same ejaculate can be something which is very abnormal too. So isolating the most competent sperm is a tedious job, actually. So then why these sperm functional tests? Because over the years, we have seen massive improvement in the stimulation protocols, and use of ICSI has improved the fertilization rate to a large extent. There has been several optimizing methodologies in the embryo culture conditions. There has been improvement in the endometrial receptivity and also the uterine competence. In spite of improvement in all of this, there has been only a marginal improvement seen in the pregnancy and the implantation rates. Why is that? Is it because we have ignored the sperm factor, or maybe because we have not looked into it as much as we have to? So the results of these sperm functional tests, we can assume that it helps in choosing the best treatment option available. And sometimes we do suggest expensive procedures for the patient just because we do not know many details about the sperm factor. But now, if we start looking into all of these factors, maybe we can provide less expensive and non-invasive tests for the couple in their quest for having a baby. So there are some common sperm function tests that we routinely practice. One is to test the sperm DNA integrity, reactive oxygen species, mitochondrial activity, acrosomal assay test, and fructose assessment, all of which we will be going through bit by bit. So the sperm DNA integrity, a lot has been spoken about this paternal genome over the last few years, and it has been established that it is very important for us to have a viable pregnancy. And the sperm with a damaged DNA is very incompatible with a normal embryonic development. And this sperm DNA integrity can be assessed through various assays. sperm chromatin structure assay, SCD, COMET, and TUNEL. And SCSA and TUNEL assay are the ones which are being very, very commonly used. So this DNA fragmentation index that is given out of all these tests, the normal reference ranges are given for all of these assays, and they definitely correlate with the drop in either fertilization rate or abnormal embryo development, or a drop in pregnancy rate when it, as far as the sperm factor is concerned. But the major limitation with all of these assays are that it is a destructive tool for the sperm as such. So though we get to know an overall view of what the DNA fragmentation index is in that sperm sample, we have no idea of knowing that the sperm that we actually pick up has got what the level of DNA fragmentation is in that particular sperm. And so in order to do that, we can go ahead with the hypoosmotic swelling test, HOS test, a brief of which was already given by Dr. Priya. And all of us have used this HOS test at some point in our lab. It's a very easy procedure to do. This we have mostly probably used in our lab to check the viability of the sperm that we're using to inject into the oocyte, especially when we're dealing with 100% or mostly immotile sperm in an ejaculate, to find out if it is live or dead. But for sperm DNA testing, we have to see the level of swelling and the level of tail curling in the sperms as such. So based on this, based on the level of the swelling and the tail curling, the live sperm are graded as grade A to G. So we call it as a normal sample when there are about 60% or more HOS reacted sperm in the sample. And there is about 50 to 60% HOS reacted sperm in the sample. It is called an intermediate sample. And when there is an less than 50% HOS reacted sperm in the sample, then it is called as abnormal. And a correlation has been seen between the HOS grading and DNA fragmentation index. So based on the tail curling and the swelling, they can be graded as A, B, C, D bar E, F, G, etc. So when all these HOS sperm based on this grading were checked with SCSA or with TUNEL assay, it showed that the tail curling with a grade D bar E, that is, there is significant tail curling at the tail end of the sperm. Those sperm are graded as D or E, and these sperm seem to have the highest HOS values. So which means that they had minimal DNA damage. And so it was suggested that tail curling, sperm with such tail curling can be used for ICSI, and which means that they have minimal DNA damage. So moving on to the reactive oxygen species, like any other sperm cell, sperm also requires O2 for their metabolism. But deleterious metabolites like ROS can alter the cell function and or maybe also pose a danger for its entire survival in itself. So why do these reactive oxygen species do? How do they attack the sperm? See, ROS basically attacks carbon atoms which are present within double bonds. And these sequences are present to a large extent in polyunsaturated fatty acids. So the sperm head has large quantities of this polyunsaturated fatty acids. So therefore, ROS can very easily attack these sperm heads, and the sperm is therefore very susceptible to these reactive oxygen species. And the cytoplasm also contains a very low concentration of these scavenging enzymes. And that is why ROS is very, very important for us to know about. So this ROS measurement can be done through all of these techniques: chemiluminescence, total antioxidant count, redox imbalance test, all of which are time consuming. the most easiest technique that can be used is what Dr. Priya has already explained. Use and color coding with a chart. That is the most simplest form of testing for ROS. So why ROS test for routine practice? Because increased oxidative stress directly affects the sperm DNA, but many of these tests are expensive or cumbersome to be carried out as routine ones. And also there is no general cure for an oxidative stress, including male infertility. Antioxidant therapy may be used because ROS, oxidative stress could be due to increased ROS production, or it also could be due to decreased level of seminal antioxidants. So providing antioxidants could sometimes lead to lower health in general for male infertility. The other is the mitochondrial activity index test. Mitochondria, we all know, is a key organelle for the sperm motility, and it is also essential for a number of the fertilization factors like hyperactivation, capacitation, acrosome reaction, and fertilization process as such. So when we check for sperm mitochondria, the parameters that we need to check are the actual mitochondrial activity inside the sperm, or the mitochondrial membrane levels, or the mitochondrial calcium levels. So there are commercial fluorescent dyes that are available to assess the sperm MMP levels. And especially when we're looking at an underlying cause of idiopathic asthenozoospermia, that is, there is very low sperm motility, even if the concentration and morphology is okay. For no reason, we have very low sperm motility, then it means this could be due to some mitochondrial dysfunctions. So antioxidant therapy is also suggested for these mitochondrial dysfunctions. Common antioxidants like zinc, folic acid, extra being used. But the major limitation is that there are no comparative studies between the different antioxidants or a combination of use of these antioxidants. And due to this limitation, we do not have a set specific antioxidant or a treatment regimen, or not do we have the rates of improvement that it can bring about in a sperm parameter and in as far as pregnancy is concerned. So there are lack of large-scale studies on evaluation of this mitochondrial function on idiopathic asthenozoospermic men after antioxidant treatment. So there are no comparison. There is no comparison before antioxidant treatment and after antioxidant treatment. So this generally seemed to improve the male infertility, but the mechanism of how it does is still not very clearly established. So there is a general lack of agreement on selecting the mitochondrial assessment test or the oxidative test and the type and duration of the antioxidant treatment that can be used for the male counterpart. So the acrosomal assay test, we know that the sperm acrosome contains lots of acrosomal enzymes, the more important ones being protease, acrosin, and hyaluronidase. So acrosin and hyaluronidase, they play a very major role in the fertilization process. And detection of these levels of these acrosome enzymes and the acrosomal reacting activity, they provide a good insight into the fertilizing capacity of the sperm. So several methods have been suggested for this acrosomal enzyme activity, assessment activity. So that would be fluorometry or Western blotting or spectrometry, substrate assays, and radioimmunoassay. And the reaction, acrosomal reaction, can be assessed by the transmission electron microscopy or dyes in bright field microscopy or fluorescent labels. But this test has taken a backseat because most IVF centers use almost 100% ICSI for any infertile couple. And it is also justified to a certain extent because for us to avoid the unexpected failure, total failure of fertilization in an IVF sample, and for us to use it explaining to the couple becomes very difficult. So that is why most of us still continue to do ICSI as a regular thing. But if this acrosomal assay test gains importance, IVF can be used for certain couples, because lots of centers are now rethinking and trying to use IVF for their as a procedure rather than ICSI for everybody. So IVF can be suggested for couple who have a higher chance of fertilization success, and this can be used by assessing the acrosomal assay test. The other one is fructose assessment, and the seminal plasma. It has very important secretions which are from the seminal vesicles and also from the prostate glands. So each secretion has a characteristic marker to detect the presence or the absence or dysfunction or the infection of the specific glands. And fructose is secreted by the seminal vesicles. Why is it important? Because it is the energy source for the spermatozoa. And exclusion of this fructose component will lead to more immotile sperm in the sample. So the seminal fructose concentration, there is a normal reference range that is being suggested. And when the seminal fructose concentration is normal, it confirms the role of the testosterone, and it also signifies that the function of the vesicle and the vas deferens are normal. But when the concentration of the fructose is lower than normal and or is equal to 0, then it could most probably mean obstructive azoospermia, and it correlates with obstruction in the CBAVD, or it could mean that there is retrograde ejaculation. When the concentration of the fructose is higher or equal than normal, it could probably mean that there is non-obstructive azoospermia because of the inflammation of the reproductive gland, which causes temporary obstruction. And because of this, there could be reduction in the fructose concentration value and sometimes reversal. So these sperm function tests definitely have a role to play in our in our routine practice. And but semen analysis, there are limitations in predicting the pregnancy outcomes and actually the sperm factor alone. To see how much of it has the fertilizing potential, that there is a limitation. But these tests that are being suggested for the sperm function have their own limitations. Lot of standardization is required, and some tests are very expensive and time consuming, and it makes it difficult for us to bring it into routine practice or suggest it for couples. So for these tests to come into clinical practice, the tests must be accurate. They have to be cost effective, user friendly, and also be clinically useful. Thank you. Thank you, sir.
Thank you, Saranya. Thank you for a very good clarity on this, especially with terms of clinical application and the ease at which you will be able to access this test and do it. And if there's any questions, please drop it in the chat box and we'll be too happy to answer it. We'll move on to the next topic, and it is by my very close friend for more than 3 decades, Dr. Sharad Bhatina. And he is going to talk to us on the medical management of male infertility. And can I have this Sharad slide, please?
Gopi,
I think, Sharad, you can share the slides.
no problem, Gopi. We'll start this.
Getting it, sir. Just a minute. 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 Just a minute.
As I've just mentioned it, he has completed about 35 years experience in treating couples with infertility. He had the first IVF gift baby in 89, first IVF twin in South India in 81, first IVF baby from frozen semen samples in India, along with the work with Dr. Pandian there. So he is a Young Achiever Award of JCI, and he has got several awards. Basically, above all these things, he is a very nice human being. Over to you, Sharad.
Thank you. Thank you, Gopi, for your wonderful words of introduction. And once again, thank you for giving me this opportunity to be with you today. And I thank the Shield Healthcare and Mr. Balaji and Mr. Subramaniam for for them to sponsor this program. No? So I'll be talking to you about medical management of male infertility. It may not be an exaggeration if I say male fertility is on the decline. Sinclair in 2000 has reported that there was a 60% drop in sperm production and a 20% drop in semen volume during the last 70 years. 50% of these couples attending the infertility may be having a male factor. Majority of these patients are idiopathic in nature, and the etiology of suboptimal semen quality is not completely understood. Coming to the medical management, which I'm divided into three components. One is specific management, which includes management of endocrine disorders, genital tract infections, and ejaculatory disorders. Then comes non-specific treatments, which include empirical treatment for idiopathic male infertility, and Dr. Saranya already said antioxidants for the oxidative stress. The medical management for endocrine disorders. Hypogonadotropic hypogonadism. For normal spermatogenesis, intact hypothalamo-pituitary gonadal axis has to be intact and to be functional. Any disturbance in this hypothalamic-pituitary gonadal axis disturbances may end up in hypogonadotropic hypogonadism. The clinical features include deficient virilization, hypertrophic or small testes, and azoospermia. Biochemistry includes pituitary hormones FSH and LH are low, and they'll be less than 1.2 milli international units per ml per liter, and the total testosterone will be less than 300 nanograms per deciliter. The etiology includes congenital, like Kallmann syndrome. Kallmann syndrome is characterized by the delayed puberty and with anosmia because the GnRH, gonadotropin releasing hormone secreting neurons, they fail to migrate from the nasal reach to the hypothalamus. So they have delayed puberty and associated anosmia or deficiency of smell. Then the other syndrome includes the Prader-Willi syndrome, which is characterized by the obesity, and they have the learning disabilities and either absence of puberty or delayed puberty. Then acquired conditions like pituitary tumors, both the macroadenomas and the craniopharyngiomas, are infiltrative disorders of pituitary like sarcoidosis or hemochromatosis, steroid abuse, and lastly, the testosterone replacement therapy for androgen insufficiency. Treatment includes human Korean gonadotropin. It will be given in the dose of 2,000 international units intramuscularly twice a week, or 5,000 international units intramuscularly once a week. 12 weeks. Then we'll assess the serum testosterone levels. If the serum testosterone levels becomes normal, more than 300 nanograms per deciliter, and if you find if you don't find sperms in the semen, then probably there's a place for FSH can be added, either urinary gonadotropin like HMG or recombinant FSH can be added to initiate the spermatogenesis. And these days, the recombinant preparations are available, and the recombinant HCG also can be given in the dose of 250 micrograms subcutaneously once a week for 12 weeks time. Coming to the treatment of other endocrine disorders, which include correction of thyroid disorders, both hypo and hypothyroidism can affect the sperm production, and both have to be corrected before we start the treatment. Then hyperprolactinemia. When prolactin levels are increased, so the prolactin levels can interfere with the pulsatile release of gonadotropin releasing hormone from the hypothalamus, which results in the hypothalamo-pituitary dysfunction. The clinical features will be hypogonadism, impotence, and galactorrhea. These patients with hyperprolactinemia can be treated with the dopamine agonists like bromocriptine or cabergoline. Then coming to the congenital adrenal hyperplasia, most of the time this will be because of 21 hydroxylase deficiency, and these patients can be treated with the dexamethasone 0.5 milligrams at bedtime. Then androgens are not, the most important point we had to note is androgens are not indicated for the management of male infertility. When you give testosterone, it suppresses the pituitary function, resulting in the lowered levels of LH and FSH, which will result in the lowered intratesticular testosterone levels, which has a contraceptive effect. So testosterone treatment is contraindicated for the when the person is going in for the treatment for infertility. Coming to the male idiopathic male infertility, so 30 to 50% of the patients may be because of idiopathic male infertility where there is no demonstrable cause for abnormal semen has been found. Then they'll have normal volume testes with normal pituitary gonadotropins, FSH and LH levels will be normal. The testosterone will be normal and it will be more than 300 nanograms per deciliter. So we'll put them under the category of normogonadotropic normogonadism. So empirical treatments are not effective, and according to the guidelines by European Association for Urology, these empirical medical treatments should not be encouraged for the treatment of idiopathic male infertility. Coming to the aromatase inhibitors for obesity and associated oligosteatoteratospermia. So obesity is an important cause for male infertility. Obesity can affect in many ways the fertility of the man. One is because of increased obesity or increase in the amount of adipocytes, there will be an increased aromatase activity, which can convert the testosterone to estradiol. And the second reason for infertility may be because of increased intrascrotal scrotal temperature may be increased because of increase in the pubic fat. No? So there will be increased intratesticular temperature, which can affect the spermatogenesis. Then leptin, because of leptin resistance, there will be increased levels of leptin in the circulation, which can affect the GnRH function. And we all know that obesity is a chronic inflammatory conditions. There will be increase in the reactive oxygen species in the circulation, which can affect the sperm production and sperm function too. Coming to the aromatase inhibitors in obesity-related oligosteatosepermia, as I already said, because of increase in the aromatase activity, the testosterone will be converted into estrogens. So, which in turn will result in the altered testosterone to estradiol level ratio, no? Which will be less than 10 in obese individuals, whereas in normal individuals, it should be more than 10. And these patients can be benefited by aromatase inhibitor anastrozole 1 milligrams per day for about 2 months time. So this study, patients were given aromatase inhibitors for obesity-related male infertility. According to this study, which was published by Raman and Schlegel in the Journal of Urology 2002, the testosterone to estradiol ratio has been improved from 5.9 to 15.6. As I already said, more than 10 will consider it as normal testosterone to estradiol ratio. Then there was a marginal improvement in ejaculatory volume from 2.9 to 3.5 ml, and the sperm count was significantly improved from 5.5 to 15.6 millions per ml. So there was a positive impact of anastrozole in obesity-related male infertility. Coming to the genital tract infections and male infertility, 10 to 20% of infertile men will be having asymptomatic leukocytospermia. That means more than 1 million per ml of semen is a marker of reproductive tract inflammation, and there will be increased reactive oxygen species production with leukocytospermia. Leukocytes are important source of reactive oxygen species in semen, and increase in the leukocytes, which in turn will result in the increased ROS production in the semen, and which Dr. Saranya has already enumerated. And genital tract infections include urethritis, prostatitis, seminal vesicleitis, and epididymoarthritis. All these structures contribute for the semen volume, as Dr. Priya already said. The common organisms include aerobic bacteria, Neisseria gonorrhoeae, and bacteroids like chlamydia, ureaplasma, and mycoplasma. So antibiotic therapy is suggested, but the effect on fertility is still not clear, which has grade B evidence. Specific antibiotic therapy can be given depending upon the culture and the sensitivity. But 80% of the patients, they may have, even though they have leukocytospermia, but they'll have negative cultures. No? So these patients can be given doxycycline empirically 100 milligrams twice daily for 2 weeks in culture negative cases. Coming to the ejaculatory disorders and medical management includes for erectile dysfunction, psychological counseling is more important. If the patient doesn't improve with the counseling, then we can try phosphodiesterase inhibitors like sildenafil or tadalafil or udenafil. And for retrograde ejaculation, alpha sympathomimetics like imipramine or pseudoephedrine can be tried. If we are not able to improve the retrograde ejaculation, as Dr. Priya said, we can take the post-ejaculatory urine can be collected, and it can be subjected for sperm preparation techniques, and these sperms can be utilized for IUI purpose. Then premature ejaculation. The selective serotonin reuptake inhibitors can be prescribed for this problem, and depoxetine has been approved by FDA for this purpose, which in turn will increase the serotonin levels and may improve the premature ejaculation. Then coming to hypogonadotropic hypogonadism, otherwise called as pure hypogonadism, which is characterized by severe oligoasthenotetrasospermia or non-obstructive azoospermia. The testes will be of normal size or small in volume, and FSH and LH may be normal or may be elevated, and the total testosterone will be less than 300 nanograms per deciliter. This is important to note, and testosterone to estradiol ratio will be more than 10. Even though the testosterone levels is less than 300 nanograms per deciliter, but testosterone to estradiol ratio is normal. At this point, we have to note it. No? Then treatment options include anti-estrogens like clomiphene citrate or tamoxifen, and the HCG, human chorionic gonadotropin, either urinary or recombinant preparations can be used. So these either anti-estrogens and HCG, they will be helpful to boost the intratesticular testosterone production, which in turn can affect the sperm production. The duration of treatment can be given for 8 to 12 weeks time, so that it will cover one sperm production cycle from the initiation to this ejaculation. So this study was done by our Ranjit Ramaswamy, and they have used empirical treatment like aromatase inhibitor, HCG, and anti-estrogens for those patients with non-obstructive azoospermia and hypogonadism who are going in for ART procedures. No? So sperm retrieval is done by microtessy, and they, according to this study, they have taken it as positive response in cases where total testosterone was more than nanograms, 100 nanograms per dilution from baseline levels. So conclusions made from this study was microtessy is an effective sperm retrieval technique in men with Klinefelter syndrome, we all know about it, and men with hypogonadism, where the testosterone levels are less than 300 nanograms per deciliter, those persons who had low testosterone levels, they respond well for the medical treatment, may have a better chance of sperm retrieval. Those patients who have responded with medical therapy, they had a better chance of sperm retrieval. This was reported in Journal of Urology in 2009, but later in 2011, same group, they have included more number of patients with non-obstructive azoospermia with low testosterone levels. But according to this study, they have concluded that men with non-obstructive azoospermia and hypogonadism often respond to hormone therapy. So they'll improve their testosterone levels with an increase in testosterone levels, but neither baseline testosterone level nor the improvement in the hormone therapy appears to affect the overall sperm retrieval and the clinical pregnancy or live birth rates. So you have to make your own conclusions after reading these two studies. No? So coming to the anti-estrogens and in hypogonadism. So the testosterone levels should be optimal. That means the first one was here. This is before clomiphene citrate treatment. Then after clomiphene citrate treatment, there was improvement in the testosterone levels. No, but if the testosterone levels reaches the supraphysiological levels, it will have a negative feedback effect on hypothalamo-pituitary axis, which in turn will result in the decreased levels of FSH and LH, which in turn will affect the intratesticular testosterone levels, resulting in the lower sperm counts. So we had, when we are using the anti-estrogens and HCG for treatment in hypogonadism, we always have to titrate against the response from the patient. So coming to the immunological infertility, to a certain extent, Dr. Priya said about immunological infertility and the anti-sperm. We all know that the anti-sperm antibodies interfere with sperm motility and functions, thereby reducing the chance of spontaneous pregnancy. And the steroids have been tried as specific therapy for male infertility associated with anti-sperm antibodies. The potential risk for side effects like weight gain or avascular necrosis of femoral head, which is a serious complication of steroid treatments, and generalized infections make steroids less preferable treatment for option for infertile men with anti-sperm antibodies. Meta-analysis of 4 randomized controlled trials revealed that no significant enhancement of fertility following steroid treatment for immunological infertility. Coming to oxidative stress and male infertility, Dr. Saranya has already said few words about oxidative stress, and the oxidative stress and male infertility, which is recognized as an important cause for male factor infertility, and 40% of men with infertility are found to be having increasing amounts of reactive oxygen species in their semen. The oxidative stress is associated with DNA defects in apparently normal looking spermatozoa, so which will contribute for the unexplained infertility. These sperms can fertilize the oocyte, creating an embryo with damaged male genome, ending up in recurrent implantation failure and pregnancy loss. And the oxidative stress or increase in the reactive oxygen species can also decrease the sperm motility due to, as Dr. Saranya already said, lipid peroxidation of this sperm plasma membranes. Sperm plasma membrane is rich in unsaturated fatty acids. And because of scanty cytoplasm, sperms have a limited amounts of antioxidant in their cytoplasm, unlike oocyte. Oocyte has large amounts of cytoplasm. So because of limited amounts of antioxidant, and if there is increase in the reactive oxygen species, what happens? There'll be, because of lipid peroxidation or lipid of the unsaturated fatty acids in the plasma membrane, what happens? The plasma membrane will become rigid, and which may interfere with this sperm motility. Same way, decreased mitochondrial ATP production. Sperms depend on ATP for their energy purposes or for motility, and because of damage to the mitochondrial membranes, there will be decrease in the ATP production, which can influence the sperm motility. So these are the various causes for oxidative stress in male genital tract, like which factors include environmental life factors like drugs, recreational drugs, abuse of recreational drugs, or smoking, pollution and radiation are primary pathologies of male reproductive system, like male accessory gland infections, or prolonged stasis of spermatozoa in the epidermis or transit, or increase in the immature and abnormal spermatozoa in semen may contribute, because as I already said, leukocytes and the immature sperms are the richest sources of reactive oxygen species in the semen. Or systemic pathologies like uncontrolled diabetes or cancers or systemic infections may also contribute to oxidative stress. So this increase in the oxidative stress resulting in the spermatozoal dysfunction, which in turn will result in the infertility. According to Cochrane Review 2011, oxidative stress is an important risk factor for male infertility and miscarriage, which has a grade A evidence. Current evidence suggests that oral antioxidant supplementation for fertile males undergoing ART procedures will improve the chances of pregnancy and live birth. Again, it has a grade A evidence. But at the same time, well-designed studies are needed to determine the best candidates for antioxidant therapy and which formulation and what dosage will yield better results. We have to do further studies. Coming to the antioxidants, markets are flooded with antioxidants. They can be divided into either enzymic antioxidants, which are intrinsic in nature, which are produced in the body, which include superoxide dismutase or catalase or glutathione peroxidase. Whereas non-enzymatic antioxidants, which are extrinsic in nature and extrinsic source, I can say, which include vitamin C and E, L-acetylcarnitine, carotenoids like lycopene or astaxanthin, glutathione, taurine and hypotaurin, zinc and selenium, and coenzyme Q10, which is otherwise called as ubiquinone. A few words about coenzyme Q10, which is commonly used for antioxidant therapy in male infertility. Coenzyme Q10 is an essential electron carrier in the mitochondrial respiratory chain, transferring electrons from complex 1 and 2 to complex 3 and contributing to energy molecule production, which is ATP biosynthesis. Coenzyme Q10 is generated from acetyl coenzyme A. The minimum daily dosage will be 300 milligrams, and it can be given up to 600 milligrams per day. And it can be given in divided doses and better absorbed when it is taken with food. The duration of treatment is at least minimum should be 2 spermatogenesis cycles, and it can be given up to 6 months time. So according to Estes and Ajay Agarwal, the ideal combination which they recommend includes vitamin C 500 milligrams per day, vitamin E about 400 milligrams per day, and folic acid 2 milligrams, zinc 25 milligrams, and selenium 26 micrograms, a period of minimum 2 months. That means from the initiation of sperm production to ejaculation we have to give, so that it will be effective. So conclusions for my talk. To conclude my talk, gonadotropins HCG, FSH, and HMG are indicated for treatment of hypogonadotropic hypogonadism, as I already said. Aromatase inhibitors are helpful in obese men with altered testosterone to estradiol ratio, and are otherwise called as aromatase hyperactivity, and associated with the oligoestenoteratospermias. And empirical treatments for idiopathic oligoestenoteratospermias is not recommended. Infertile men with hypogonadism, when the total testosterone levels are less than 300 nanograms per deciliter, are candidates for anti-estrogen treatments and HCG treatment. And antibiotic treatment is suggested in genital tract infections, but the effect on fertility is still not clear, which has grade B evidence. Then oxidative stress impairs sperm function and is a risk factor for male infertility, which has a grade A evidence. And the oral antioxidant supplementation for suffering may improve the chances of live birth for couples undergoing ART. Again, it has a grade A evidence. At the end, I end this talk by saying well-designed studies are needed to determine the best candidate for antioxidant therapy and which formulation and dosages give better results. I once again thank Dr. Gopi for you, and I wish you all a happy new year and a wonderful year ahead. And I thank Mr. Balaji of Shield Healthcare for organizing this webinar. Thank you, and all. Thank you, Gopi. Gopi, you have to unmute.
Thank you for that very crystal clear message on male infertility. The medical management is really a dilemma, whether you really have to give or whether are you wasting your time, are you giving the optimal dose. There are some answers which we could just get out of your talk. I think all of them will be benefited in putting them into the clinical practice. Without wasting much time, I'll go on to my next talk on ART in male infertility. Before I start my talk, I have a kind request to Dr. Sharath. Please stay back and conclude the session, as I have to go and chair a session at 6:30 where Dr. Nalini Mahajan is talking. The ART in male factor infertility, you will see in most of the cases today, about more than 50%, you will say that it will be in the male factor infertility. So that is the reason it has gained so much of the importance there. The flow of my presentation will be on introduction, IUI and ICSI indications, pre-IVF evaluation, male to optimize the results, medical and surgical management of pre-IVF, sperm selection for ICSI, ICSI for male factor outcome, evidences and recommendation, and then conclusion. As we have just mentioned that more than 50% cases where it is on male infertility, ART for male infertility is becoming more and more popular, gaining more interest because the results are also rewarding today. Assisted reproductive technology includes, if you take an extension of that real true ART, even an IUI, IVF, and ICSI, and we will see it. If you look at that data from the donor sperm, surgical sperm retrieval, ejaculated sperm, IVF, and IUI, and natural conception, there is always an increased desirability towards natural conception. Whereas if you just look into that, the decreased risk and other thing, decreasing the risk and cost, it goes down to the lower level. So you have to balance based on that patient's need, where all you can get into that male factor. So you can have a normal male factor where you can combine it with the normal responder or a poor responder or a high responder, where it could be odds, borderline odds or a severe odds, which can be against normal responders or a poor responder and hyper responder. Then we can have a truly an azoospermia, which could be obstructive or a non-obstructive. In all these clinical criteria, we might have to do. That is a challenge for us. The question is, do we have a conventional IVF, which is much less effective when semen characters are grossly below the standards values as per the WHO reference values? So here, there is a complete fertilization failure has been reported as about 50% of the conventional IVF for couples with moderate male infertility. This occurred in less than 3% of the couples undergoing ICSI. So if you look into that, that is the reason. Consequently, ICSI has been applied world over to treat severe male infertility. But however, routine use of ICSI in a non-male infertility is not recommended to improve the clinical outcomes. If you look into that ICSI indication, it can be a male factor where it could be ejaculated or epididymal or testicular factor. It could be a non-male factor. Again, it could be an ejaculated on various levels. It can just go on. So the intracytoplasmic sperm injection, when you take it, there is a success rate and then complications of ICSI. You see the fertilization rate goes as high as about 80%. Live offerings come to about 20 to 40% in younger women, where the success declines with the advanced maternal age. So this is the bottom line. You might have a good fertilization, the take-home baby rate goes out. Do we have to evaluate medically and surgically manage them before you do an ART? Dealing with a high DFI before ART, what do we do? Antioxidants before ART, is there a role? Genetic testing before ART, if at all you want to do it, why? Managing a varicocele before ART, is it mandatory? Deciding on the sperm retrievals before and during ART. If you see the sperm source and its outcome in a case of IDFI, ejaculate versus testicular sperm, you will see that the take-home rate has been proved to be much more effective, and then ejaculated the testicular sperm. So this is there is oocyte's ability to repair and restore the DNA damage is one important factor which has to be considered. The testicular sperm in an IDFI results in the testicular sperm in IDFI is definitely inconclusive. Variations in the normal method of analysis of DFI. Then there is a role of oocyte repair in the restoration of sperm within the 48 hours. The ability of the oocyte to repair has to be considered. It can be considered in patients with high DFI, particularly with a history of miscarriages or failed induction. As answer to a question raised by Dr. Sharat, here we have done a fixed dose therapy in antioxidants in the treatment of idiopathic oligoacinospermia. This is a randomized, double-blind, placebo-controlled, multicentric trial which has been done in various centers here. And then the conclusion was exogenous administration of fixed dose combination of this is a safe, effective therapy in improving about 30% in the fertility factor and about 25% in pregnancy rate. So again, just to highlight about what Sharath was mentioning about it, go through the ratio and then in an appropriate medical treatment definitely will help in retrieving a better sperms there. Even you see that in a case of medical treatment prior to the sperm retrieval in a client filter, you will see here before testosterone level and post-treatment, the response was much, much better in the post-treatment. This is exactly the reason they should be treated before an ART. What is the role of genetic testing before an ART? We all know that we go for a Y chromosome microdeletion test. The scenario here, when the sperms are less than 5 million, you do it for a Y chromosome microdeletion, probably look into the karyotyping there. If it happens to be a no sperm or a testicular failure, you go for a Y chromosome microdeletion and then karyotyping. If it happens to be an idiopathic obstruction with a vas obstruction, you have to go in for cystic fibrosis in both partners, which is very, very important in order to decide. So this is how the significance of the ART in the pre-ART genetic testing. If it happens to be a AZFA deletion, you will not be able to retrieve. Whereas if it happens to be a B deletion, again, you will not be able to retrieve. If it happens to be only a C deletion, about 70%, something like you clinically examine. If it's a very small volume test, you look for FSH. If the FSH is normal, you go for a Y chromosome microdeletion. If only C is deleted or if there is no deletion, then you can straight away go in for a teaser without any issue. So whom do you do it? Deletion is linked to the spermatogenetic failure. It is a severe oligoacinospermia, especially in a non-obstructive azoospermia. We have to do it. The principle is it is a PCR of the lung of Y chromosome, and it is from peripheral blood. Diagnosis and predictive value for sperm retrieval is very, very important there. What about the pre-ART varicocele? 35% with the subfertile men, a low sperm count and motility, lower sperm functions, and then they have very high elevated oxidative stress levels. So there is an elevated DNA damage is also very high there. So you will see here the treated varicocele, whereas again the untreated varicocele. When the fertilization rate, there is a 2PN percentage is about 78 when compared to 66. Live birth rate is 46 when compared to 31. Miscarriage rate is higher when it is not treated, 31. When you're treating it, you are bringing down the miscarriage rate. So this is exactly the reason. If you have a demonstrable varicocele before ART, it is better to do a correction and then take it up thing. So here again, if you look here, sperm retrieval in ICSI in men with non-obstructive azoospermia, treated and untreated varicocele. Blue is where it is a treated, which is 53%. If it is untreated, which is about 30%. So practically you will say that it is doubling. So this is two papers essentially tells us, and you have to do it. The pre-ART varicocele, the best treatment modality in the microsurgical repair, especially an inguinal approach, is much more convenient and safer when compared to a laparoscopic, where you almost rule out you are not able to obtain the cremastic veins when you do a laparoscopic procedure. They allow fresh sperms for IVF in ICSI, even if the patient remained azoospermic. When you try to do the test TISA, you will be able to just get a better thing. You really have to confirm whether it is an obstructive or a non-obstructive. Based on that, you will be able to just take a decision there. The retrieval techniques, again, it's always, there are several procedures has been described. Now, percutaneous, the epididymal sperm aspiration, which is again has become a little bit obsolete now. Microsurgical epididymal aspiration, MISA, was very popular. Now, practically, we confined to the testicular sperm aspiration, where because the patient cannot come for repeated attempts, we just try to take a chunk of the tissue as it is shown there in the picture here. And then we just try to analyze it by cutting it into small pieces and then directly going through it. And then we'll be able to do it. You will see the success. And in a micro TSA, it goes by about 40 to 67%. But however, you should have an expertise. You should have a good operating microscope. The patient should be, their doctor should be able to spend about 4 hours or 3 hours continuously with the patients to go through the micro-procedure. Now, having obtained that, when you just try to get what are all the newer techniques for sperm selection? So this is a magnetic activated sperm sorting, what we call it as a MAX. Then we have a PIXI, IMSI, and PIXI and IMSI, and then microfluidic techniques. So these are all some of the apoptotic like EPS DNA fragmented sperm, which have an affinity to be labeled by an annexin V conjugated magnetic spheres. So by this way, you can just take it. Or if you have a good microscope where you will be able to see a enlarged view, like how you see that first is a normal sperm. When you enlarge, you see so much of the defects there, which you will be able to eliminate it there. PIXI is again one of the very useful selection of hyaluronic binding spermatozoa. And in selected cases, the PIXI dishes are available where ready-made dishes are available with which you will be able to do it. Microfluidic, again, is a very useful normal type where you have sets of, you put a medium, you put a semen here, and it goes through the microfluidic chip here, and then at the outlet, you will be able to take the waste and then the motile sperms are there. It is at least invasive. When you think in terms of an outcome, they have just mentioned it's about 5% birth defects were seen in about 7.2 to 9.4 in a spontaneous consumption and an IVF and ICSI separately. The increase reflects increase in chromosomal abnormalities associated with severe sperm abnormalities. So ICSI should be reserved for those who absolutely require it and should not be used unnecessarily. The ICSI outcome, the origin of the sperm used in ICSI cycles do not have a major influence on the early life outcomes of the offspring. Long-term effects or the transgestational passage of the male infertility to the genetic remains unresolved there. Genetic counseling should occur before the treatment if it is a risk of transmitting genetic defects, and then the PGT and fetal testing should be offered to them. To conclude, nearly all men and male factor infertility are treatable with assisted reproductive technology. Antioxidant preparations to subfertile men is recommended, especially in cases of increased ROS. Microsurgical varicocele repair definitely improves the ART outcome. Reproductive potential of surgically retrieved sperm depends upon the type of azoospermia. Genetic counseling and testing should be considered before ART for a severe male factor infertility. Severe male factor infertility is an absolute indication for use of ICSI and sperm selection. Application of ICSI for severe male factor infertility can allow pregnancy rates as high as about 52% as per the thing. Thank you very much for your patient listening. Sharath, may I ask you to conclude, please?
Yeah. So you want to say a few words before you leave, or shall I go ahead? Mr. Balaji? Yeah, Priya.
Yes, Doctor.
Balaji,
Doctor,
yeah,
there
are you
is
there?
one question in the chat box.
Yeah. Any questions, Priya?
There is one question in the chat box, Doctor. Hello.
Sudhamani, yeah. Dr. Sudhamani says, does the treatment of erectile dysfunction in diabetes will improve the sperm count? Erectile dysfunction is different from this one, no? Sperm count, semen parameters. No, I don't think by improving the erectile dysfunction, I don't think there will be improvement in the sperm count. Priya, would you like to say anything on this one?
So I think you just have to treat the underlying diabetes, and we have to counsel the couple, which is more important, from time to conception or treating the dysfunction and then procuring. So, like you rightly said, we'll treat the underlying condition and then jump straight away to ART and other methods of sperm retrieval, I guess.
Balaji, any other questions are there? Balaji?
Sir, I will just check it, sir. 1
Yeah,
minute.
please. But anyway, I can say it's a...
So there are no other questions, sir.
Yeah, then fine. So I'll conclude the session then. Yeah. So it's a good evening, everyone, and it's a wonderful webinar, and it's an academic phase, no, I can say, on male infertility. All the speakers, they did wonderful presentations. Priya, you made me to know so many things about semen analysis, because day in and day out we'll keep seeing so many reports, no, but we never get into the depth of it. No? So you made us to realize, no, there's so much into semen analysis. No?
Thank you so much, sir.
Yeah. Thank you so much for
I've taken all your snapshots of your selection. Really good, and even Dr. Saranya did a great job.
Yeah.
Well, so thank you so much of insight.
Yeah. So same way, Saranya also, no, so many things she said about the advanced methods of semen analysis and sperm functional tests, and Gopi, as usual, no, so he enumerated so many new things about ART procedures for male infertility, and I thank all the participants for their valuable time, no, and spending time for us, and I thank Mr. Balaji and this Shield Pharmaceuticals, no, for sponsoring this webinar. No? Would you like to say anything, Priya?
No, sir. Just thank you very much for this wonderful opportunity, and we kickstarted the new year with so much of insight into male infertility, a topic which is always debatable and with so many different views. So I really wish to thank Mr. Balaji and Sajita and everyone from Shield Healthcare who have given us all this opportunity, and of course to you and Gopinath sir for including, Saranya and me in this. Thank you so very much. Thank you.
Yeah, one more thing we had to say, na, they made us to sit and study, na, what was said and done. Otherwise, so we'll take it.
Yes, of course. That's
so we'll become students once again, na, before the webinar. Na.
That's what I really enjoy about these webinars.
Thank you, Balaji, once again, na, for this webinar. Na. We all really enjoyed about it.
So on behalf of Shield, I thank every one of you, Dr. Gopinath sir, Sharath sir, Priya madam, and Sharanya madam. And I thank all the audience for sparing your time today. On behalf of Shield, we wish you all the best in this 2021. Wish you a very happy new year. Thank you very much. Thanks, everybody.
Thank you. Thank you, Balaji.
Thank you,
wish
sir.
you all
Thank you
happy
very
new
much.
year once again. No? Thank you.
Bye.
Thank you, sir.
Right.